slides
Yeah.
where prostin was introduced, and we can reduce a bit of amount of slides. Yeah.
Yeah. Okay.
Can you share this your screen with us so that we can see?
Yeah, I will. Yeah.
Cheers. Thanks.
Yeah. So
Thanks.
Can you see the screen now?
Yeah.
Got it. Lovely.
Yeah. So I'll just start. I just recapitulated what was told last time. So a bit of anatomy, what are the types of presentation, what exactly. I'm not gone on details on clinical examination or investigations, but these are the investigations that help with the management. Of course, the treatment, Ansh has described a lot of surgical aspects of this. We need to try to close the VSD. We need to try to reconstruct the outflow tract, whatever it means. To establish a good pulmonary flow. Of course, that depends upon the anatomy because there are varied anatomies. It can be a single stage procedure or a multi-stage procedure. When it comes to prenatal diagnosis, it plays a very important role because not just pulmonary atresia, VSD, it is associated with other syndromes like DiGeorge syndromes, which are quite common in this, and hence it needs to be diagnosed, which is happening in most of the patients nowadays, unless they miss the prenatal scans. Termination pregnancy was almost more than 50% earlier, which has reduced now because of the improved surgical outcomes and the better prognosis. However, there are no in utero deaths in cases which are diagnosed prenatal. Natural history, if they only have the ductus arteriosus, they are prone to close. They become very hypoxic. So only 10% survive the age of 1 year. If they have some MAPCAs, they're still present with cyanosis, but it's opposite. 10% die by the age of first year, 50% by 3 to 5 years, and 90% by the age of 10 years. Remember, the natural history are all data that have been given in books which are quite old, maybe 15, 20 years earlier. There's no natural history of these patients now. There are only modified histories. Natural history in patients in large MAPCAs, of course, their presence, they are balanced kind of, if they are kind of balanced circulations, they don't have congestive heart failure, they survive until pulmonary vascular disease begins, they die by the age of 30 years. Modified history is because of the various type of shunt surgeries. Earlier, the shunt surgeries were highly morbid. Of course, the invention of prostaglandin can be described as a fortune for these kids. One of the main contributions of second half of the 20th century, where mortality of the babies were reduced because the mortality of children operated in the first week was double as compared to those in the second week earlier. This was older reports, as I'm just quoting, but now the reports now the results have improved because of the modification of the surgical techniques, the modified BT shunts, central shunts like Me shunts, Melbourne shunts, of course, the earlier water shunts and spot shunts, which have been abandoned totally due to a lot of difficulties either in performing the surgeries or taking down the shunts during the corrective repair in future. There have been a lot of interventions that are being done, like perforation of the pulmonary valve, if possible, RVOT stenting procedures, if they have a good confluent pulmonary artery and a good pulmonary artery confluence. And of course, the better postoperative care because the number of shunts being done is increasing, and hence a better understanding of the post-operative management of these children. These kids, the mortality of these cases have come down drastically. Because of these things, which we see more kids who survive childhood, who reach adolescence or even adulthood, either being operated or palliated, or most likely either unoperated, which is very unlikely, being palliated, which is more likely, and much more likely being operated and undergoing a complete repair. So what can we see in these kids? These kids who have been palliated, they usually have reduced oxygen saturations, or still present with cyanosis, because though they have a shunt, they still have inadequate pulmonary blood flow. There is obviously a continuous murmur over the back or the lateral aspect of the chest, which is usually associated with MAPCAs or shunts. We should not forget to auscultate for these things in continued follow-ups, because a disappearance of continuous murmur, which has been previously present in a patient, heralds either shunt occlusion or the development of pulmonary hypertension in patients who have not undergone further surgeries due to whatever reason after undergoing a shunt procedure because of the persistent unrestricted pulmonary blood flow by these shunts. They can have signs of right heart failure or signs of LV dysfunction subsequently in their course of period. Unoperated or palliated patients can still present with aortic regurgitation. I will describe further about the progressive root dilatation in the subsequent slides. They can present with arrhythmias, which can be supraventricular arrhythmias, commonly atrial fibrillation or atrial flutters, reentrant arrhythmias. They can be ventricular arrhythmias, basically because of the myocardial abnormalities that are because of the RV muscle anatomy in these patients. They can be because of ventricular dilatation per se, or because of ventricular dysfunction. These patients have frank cyanosis, they can have polycythemia and have an intracardiac shunt, and because of this, they can present still with paradoxical emboli and in situ thrombosis due to polycythemia per se. Why this happens? Usually unprotected pulmonary blood. I mean, these patients usually have unprotected pulmonary blood flow, and if they have a shunt for a longer time and they don't undergo any further surgeries, they can present with Eisenmenger physiology. They can most of these MAPCAs undergo stenosis over the due course of years. So if they undergo stenosis, they can present with frank cyanosis because of limited pulmonary blood flow. So as I've told, that have undergone a shunt or unifocalization earlier, but surgery may not have been possible because of some other reason, and hence these patients remain to be cyanotic. And there is this feature of segmental pulmonary hypertension, which is very pertinent when it comes to the discussion of pulmonary atresia, VSD, and MAPCAs. So what do we see in patients who have operated or who have undergone complete repair? These patients should have normal oxygen saturation. They should have a thrill or an ejection systolic murmur because they have a RV to PA conduit in position. They can have a loud palpable S2, not just because of the RV to PA conduit in position, because otherwise they have an aorta that is more larger and more close to the sternum. They can have a loud and palpable S2. Because of the conduit, it is not a conduit which is perfect to the size, so they can still have some ejection systolic murmurs. There can be a 2-1-4 murmur if they develop a conduit regurgitation. A continuous murmur can still be present because not all patients who have undergone complete repair may have undergone MAPCA ligation during surgery or MAPCA coiling before surgery, or maybe MAPCAs can open up after the surgical procedure sometimes, so they can have a persistent MAPCA or a shunt, which, of course, unfortunately to say, if they have been forgotten during the procedure to be clipped or ligated. Now, it can very rarely happen, of course. After a complete repair, because of the conduit stenosis and the conduit stenosis, they can present with features of RV pressure overload. Not just the conduit stenosis, they can still have problems with branch pulmonary arteries, which can be stenosed per se because of the anastomosis, or they can have stenosed in unifocalized MAPCAs, which can happen because they may not develop as expected to grow. They can still have hypoplastic pulmonary arteries, which may not grow as expected again, and of course, which we cannot handle much. They have arborization defects of the pulmonary vasculature, and because of this per se, they can have RV pressure overload. They can further present with features of tricuspid regurgitation, and of course, even though they are operated and have undergone complete repair, aortic pathology can still progress, and they can present with aortic regurgitation, aortic root dilatation, and complications of aortic regurgitation per se. These patients can still develop endocarditis because there's a conduit in position, which is a foreign material, which can, of course, like anything, like any other organ, can develop endocarditis. Though they have been operated, they can still develop arrhythmias. Supraventricular arrhythmias are still common. Ventricular arrhythmias can also occur per se because of the RV incision, ventriculotomy. There has been a VSD that has been closed. There can be sutures in the ventricle. There is a patch in the ventricle, which again predisposes for arrhythmias. Again, they can have right heart failure or left heart failure. So there have been conduits. So what are the the material we use for complete repair? We use conduits. The conduits can be homografts. They can be stented xenografts, stentless xenografts, autologous tissue conduits, or expanded Ptfe valved conduits. The homograft was first described in 1965, and this was described for reconstruction of RVOT of tetralogy fellow with pulmonary atresia. It has been a gold standard for a lot of years after its description and was a gold standard in Western countries. However, they've not been very popular in the East because of shortage of donors and developing countries, of course, because of issues in procuring the homografts. So because of this, there have been invention of stented xenografts. This is a Hancock xenograft that we can see. There is a Ptfe tube and so this is a Ptfe tube, and inside a Ptfe tube there is a bioprosthetic valve, a porcine valve that has been incorporated, and we can use this as a conduit for reconstruction. This is the Medtronic freestyle graft, which is a stentless graft. This stentless graft has not been famous because of issues with procuring these stentless graft. They have not been manufactured in large numbers, of course. They are costlier. This is difficult to procure. This is easier to procure, but costlier. And they have a lot of problems per se. So there have been a lot of stentless xenografts that have been described. And one of those is Contagra, which is most commonly used nowadays because of the ease of procurement of the Contagra. It's a bovine jugular vein graft, which has a tri-leaflet venous valve in position that helps in the course of surgery. There have been reports of using ePTFE conduits. These are not commercially available, though this looks like they're commercially prepared, but these are all prepared by indigenous techniques that have been described by surgeons in certain institutes. They are prepared on the table. They show promising reports, but they are not yet used in a widespread manner. So whatever material we use for surgery for preparing RV to PA conduit, conduit stenosis and regurgitation happens. Conduit stenosis is the most common reason for problems occurring with RV to PA conduits or for reoperations. Conduit stenosis or regurgitation can occur in isolation, usually occur together. Conduit stenosis is much more commoner than isolated regurgitation. Why conduit stenosis happens is because most of these conduits are implanted in small patients, and these patients obviously grow, and the conduits are outgrown easily by the growing kids because these conduits don't grow with them. Compression by extrinsic suctures. Why we can't use bigger conduits in younger patients? Of course, because if you use too bigger conduits, then the body is so small in these kids that they can be compressed easily by extrinsic, especially the sternum. We have techniques where we can put the conduits laterally to avoid compression. Whatever it is, if the compression occurs by the sternum, they can be easily distorted and they can cause early regurgitation and conduit failure per se. Size of the conduit is also restricted by the size of the right ventriculotomy, because the right ventricle is small, the heart itself is small, so we cannot make a huge ventriculotomy because they can cause ventricular dysfunction per se. So it has to be guided by the size of the RV as well. Coronary anomalies are quite common in patients with pulmonary atresia, VSD, MAPCAs. So there can be coronaries that are crossing the site where the ventriculotomy needs to be made. So this can as well reduce the size of the ventriculotomy and plays a role in reducing the size of the graft that is being implanted. Again, the distal pulmonary arteries are small as well. Whatever size of the bigger conduit we use, there is some restriction to the distal pulmonary artery anastomosis that we can make, and hence the stenosis can happen at the distal anastomosis site as well. Other causes of conduit degeneration is conduit calcification, because we are using homografts. We can use Contegras, a porcine valve like Hancock. All these are have preservation techniques. There are a lot of modifications in preservations, glutaraldehyde, low concentration glutaraldehyde, a number of techniques of preservation, but whatever they have, they are prone to calcification. That's the reason why ePTFE conduits have been used in by a few surgeons, of course. They can per se undergo degeneration or shrinkage of leaflets over the period of time. Unfortunately, these leaflets can get lacerated during implantation if you are not careful. We need to be meticulous during implantation. Be careful while handling these valves during the surgery so that we don't cause intentional lacerations into these valves during implantation. As I've told, these valves or implants can develop infective endocarditis, and they can present as leaflet perforations, leaflet destructions totally, and sometimes formation of pseudoaneurysms. True aneurysmal dilatation of the conduit can also happen, but this is rare, but cases have been reported with true aneurysmal dilatation of the conduits in cases where contact grafts have been used. So this is just an example of conduit calcification. We can see that this is the conduit that is implanted from the right ventricular outflow tract to the PA, and there is the calcification of the conduit. This is a CT image showing calcification of the wall of the conduit and as well as the valve that is in position. Sorry for the image. This is taken from as a snapshot from a video. We can see here this patient is a case of pulmonary atresia VSD, who's already underwent a conduit earlier and is already on pump. We can see that the heart is collapsed. And here the patch that has been used from the RVOT to the conduit is collapsing because it is not calcified. But the conduit per se, which has been implanted here, you can see it is not collapsing. That means to say it is highly calcific. You would have been seen better in a video, but I did not want to show a video here. And once this conduit was opened, we can see that this conduit is calcified, and this is the valve shown here, which is shrunken, totally deformed, leading to both conduit stenosis and conduit regurgitation. Now, there have been a lot of reports in literature regarding the fate of right ventricular to pulmonary artery conduit. This is one of them by the Department of Cardiac Surgery, Stanford University. They started with the discussion that conduits, their hypothesis was that conduits will have different longevity in pulmonary atresia, VSD, and MAPCAs, particularly because the pulmonary arteries per se in these patients will have higher pressures after unifocalization procedures than in any other congenital heart defects, and this high pulmonary artery pressures can affect the outcome of these conduits. They had a retrospective review of 103 patients, usually infants. They used iotic homograph conduits in all these patients whom they had operated, and the age at complete repair was 5 months on average. This was much earlier age, and the average, they used all size of conduits, 8 to 11 mm, 12 to 14 mm, and 15 to 17 mm. And as we can see, as the size of the conduit increases, the longevity of the conduits increases as well. The smaller conduits have less longevity. The larger ones, 15 to 17 mm conduits, have larger life. Other reports like this report from Columbia, British Columbia, reports a retrospective study of 49 patients. They have used contact graph aggressively in this study. They had reviewed the conduit replacements that have undergone in these patients. The cause for conduit replacement was conduit stenosis in 67 patients, 67%, regurgitation in only 12%. As I told, it is more common, stenosis commoner, regurgitation is less common. Combined cases are 18%, endocarditis has been reported in 3%. 10-year freedom from reoperation on the basis of age of implantation. Surprisingly, the age of reimplantation earlier, the 10-year freedom was 47%. I mean, it is less, and 83% for as the patient reach elder age. I don't know why this reason was, because it was not described. The 10-year freedom for reoperation was just 44% for adulthood. It was surprising because as you implant new conduits in adult patients, the conduit should be surviving, or a freedom from the reoperation should be higher in adult patients, but it was less as compared to the adolescent patients in this study. Of course, the second conduit implanted was significantly larger than the first conduits. That is obvious because you have a larger patient by that time. There is no significant difference in the size between the second and third conduit because they would have reached a certain body surface area, after which we cannot really increase the size of the conduit. Or once you reach a certain conduit, you don't have bigger and bigger conduits as and when the patient body surface grows. You have a limit for the availability of the size of the conduits as well. 10-year freedom from reoperations, you can see here after the first conduit was just 51%, second conduit for 75%, and after the third conduit reimplantation is much better, 95%. But you can see these patients have undergone 3 conduit replacements, which is kind of the norm in pulmonary atresia VSDs who undergo conduit replacements. This is another study from Tokyo. This describes the experience, 10-year experience with handmade Tri-Leaflet Ptfe valve conduits. We can see that most of these kind of studies are from Japan or Chinese institutes. They made these Ptfe conduits using Ptfe patches. The valves were stitched by the surgeons on table. Here you can see the patients with pulmonary atresia, VSD, was again the predominant group of patients. Why they are using Ptfe conduit is because they say that the Ptfe has very low tissue affinity, hence cellular and fibrous deposition is unlikely to happen in Ptfe patches. Of course, this is less as compared to homografts or Contegra, but it cannot be ruled out because definitely there can be intimal proliferation in shunts or Ptfe conduits as well. Chemical inertness, of course, definitely the valve leaflet per se does not undergo degeneration, but they can still undergo fixation in semi-open position, as we have seen in monoleaflet or bicuspid reconstruction of the tricuspid, of the pulmonary valve in tetralogy of Fallows studies. But surprisingly, this study, they say that the late valve fixation in semi-open position did not occur, and the pressure gradient reaches a plateau, and after that does not increase. So that was a surprising description after 10 years of study of ePTFE valves, and no reoperation was required in these patients because of structural deterioration. And they described, they came to the conclusion that the Ptfe is ideal biomaterial for valve replacement, especially in pulmonary positions, and Ptfe conduits have comparable longevity as compared to homografts or Contegra. They did not say better, but comparable longevity still. This is another study regarding the Contegra conduit. There was again, but this patient, the study has all kinds of patients who have underwent Contegra conduit replacement. They have implanted size of conduits 12 to 16 mm to 18 to 22 mm, almost same number of patients in this study. They saw how many of these patients underwent reoperations. Again, they had reoperations with conduit stenosis, distal stenosis because of fibrotic reaction in the distal anastomosis. In both group of patients, there's not been any significant variation. Why conduits like Contegra are preferred because homografts is difficult to procure, Contegra is readily available. Homografts are costlier as compared to Contegra's cost. They don't have to be prepared, they're already ready, so ePTFE grafts have to be prepared on table, they're not commercially available, the Contegras are still preferred. They claim that Contegras will grow with the patient. I don't find any reason why the Contegra should grow with the patient. Maybe they enlarge and cause regurgitation, but I don't think that they grow with the patient. They elicit minimal response is what they claim to, but unlikely, because we can't agree with the claim totally, because a Contegra is still a tissue. It can still elicit immune response. There is glutaldehyde used for preservation. Glutaldehyde definitely causes degeneration to some extent. And once the valve or the Contegra per se degenerates, you can have immune response as such. Of course, they are using low concentration glutaldehyde nowadays and improved. They claim that the Contegras which have low concentration glutaldehyde for preservation have better outcomes as compared to the earlier Contegras which have high concentration glutaldehyde. Better washing of the Contegra has been advised to prevent these problems. And use of smaller conduits like 12 to 16 mm can still, because the Contegras are available in such small sizes, they can be used in very young patients. So that's the advantage with Contegra, and hence the number of patients who are undergoing RV2PA conduits with Contegras are increasing ever and after. As I've already described, this slide doesn't carry because most of the patients are small, and this is the same repetition of the previous slide. Then comes the other important problem that happens in RV2PA conduits is infective endocarditis. This, though, is very rare in occurrence, but they are one of the important cause of conduit insufficiency. The cause of infective endocarditis in these patients can be as common procedures like dental procedures or skin infections, even dental procedures which have been undertaken with proper prophylaxis have been described to be having infective endocarditis or causing infective endocarditis. But of course, there are strict guidelines for any dental procedure that has to be done with these patients. It was surprising, even an open heart surgery done, a redo surgery or a cardiac catheterization can per se induce infective endocarditis in patients that can cause problems. A prolonged transesophageal echo has been described in studies to cause infective endocarditis in these patients. Of course, the other causes are not in our hands, intrauterine device placements, therapeutic abortions. These patients may not be under the cardiologist follow-up always. Especially in developing countries, they can have these procedures and they can come back to you with infective endocarditis. Some surprising microorganisms and causes have been described in isolated case reports, like infective endocarditis in a patient who has undergone RV to PA conduit replacement, is a sewage worker and has developed infective endocarditis. A person who's been living under a chronically leaking ceiling has developed infective endocarditis. And of course, a patient who's undergone surgery or some other procedure, if he stays prolonged for a prolonged stay in the ICU, can develop fungal infections and infective endocarditis of the conduits. So there has been this study from Houston where they have studied the incidence of infective endocarditis and reintervention in patients who underwent RV to PA conduits. We can see that overall there have been 792 patients that have been studied who have undergone conduit repairs, homografts in 410, bovine jugular and porcine heterografts in 245 and 137 respectively in various age groups. As we can see, more common neonates, elderly the numbers as the age goes on is coming down. But the most common surgery in this was tricuspid atresia, pulmonary atresia, VSD. The numbers you can see for yourself, 106 homografts, 90 bovine jugular vein grafts, and 52 porcine heterografts. The microbiological the organisms that are usually responsible for endocarditis were the streptococci, staphylococci, and other organisms which I'm not described in this. They have been described in those papers. And few patients had negative cultures as well, unfortunately. They concluded that the bovine jugular grafts had a significantly higher incidence of endocarditis than iotic homografts or pulmonary homografts and porcine heterografts. Now, this is one blow for contact graft proponents, higher incidence of infective endocarditis. They conclude that the surgeon and the family must balance the risk of endocarditis with conduit durability. Now, this is a question you put the surgeon or the treating physician and, of course, the family in a fix, because you definitely cannot have, you cannot definitely predict what is the best conduit that can be implanted. This was a study again from Alberta, Canada, that showed an increased incidence of endocarditis in conduits in patients receiving bovine jugular vein grafts as compared to cryopreserved homografts for RVOT reconstruction. Here, the age of the patients, they are used bovine jugular vein grafts in 250 patients and homografts in 135 patients. Of these, 84 patients were for pulmonary atresia VSD. I have not shown other surgeries here. Of these, there were 24 cases of endocarditis, of which you can see there are 23 cases alone in bovine jugular vein grafts, that is the Contegra. All cases, though, have been reported more than 6 months after surgery, few even after 5 to 6 years after surgery. Now, they concluded that the incidence of endocarditis risk is very high in case of bovine jugular graft as compared to homograft. Now, with these homografts being, with the bovine contact grafts being easily available, with this high incidence of infective endocarditis, we really need to decide what we have to use for RVT-PA reconstruction. And also they stressed upon the need for prolonged attention to lifestyle measures that reduce the risk of infection in these patients, and hence they have to be kept under strict follow-up and need to be advised as to what to do and what not to do. And they also stress upon the importance of drawing blood cultures early during the course of any febrile illness in patients who have already undergone or have a history of implantation of bovine jugular vein grafts, or for that matter, any graft, I should say. Now this one last paper on outcome of RV to PA conduit for biventricular repair from Arkansas. They have studied all conduit reoperations that's total of 159, in which these are the numbers which shows that you can see that they have used more of homografts and equal number of Hancock conduits. Stenosis, again, is the most common cause of reoperation. Regurgitation is the next common. Combined stenosis regurgitation is the next common. Regurgitation isolated is the less commoner, and infection, of course, is described here, and very rarely aneurysm. So this is just a slide to show that these are the complications that again can occur in a patient who's undergone a conduit treatment. Other rare complications like RVOT aneurysms or pseudoaneurysms or thrombus formation can happen in these patients. It's a very rare complication, though have been reported in isolated case reports. The progression of aneurysms usually will be very slow and will be described after many years of surgery. Pseudoaneurysms, in case they are identified, they usually start earlier after the surgery, but they usually tend to take time before they are diagnosed, because by the time they tend to start presenting symptoms, if they are not under follow-up properly, is very late during the course, because they are present only with secondary compression of the adjoining structures, maybe the cardiac or the compression. They're extending into the lungs. They cause compression symptoms over the lungs, dyspnea, cough, hemoptysis, other things, or they can compress on the conduit itself and cause symptoms of stenosis, conduit stenosis. Now, why this happens, pseudoaneurysm, is because there will be exposed, in patients with pulmonary atresia, VSDs, they are exposed to a high pulmonary artery pressures, distal pulmonary artery pressures. This elevated pulmonary artery pressures will lead to a leak of blood from the suture lines, which may be loose at certain point, or maybe because of the dilatation after a few weeks or months, and these gradually cover with a fibrinous layer, or maybe by the pericardium, and get restricted and slowly keep on increasing. This is one such case report which has been reported. As you can see, that this is an RV to PA conduit that has this has developed a pseudoaneurysm and as presenting as a mass in the left side of the chest. This is the echo featuring the pseudoaneurysm. You can see there is a blood that is entering from the RVOT here, and this is causing compression over the conduit. The gradient across the conduit was 65 in this case, and they did a CT which shows a classical description of a pseudoaneurysm arising from the RVOT anastomosis and compressing on the main part of the conduit. So all these conduit dysfunction, conduit stenosis, compression of the conduit, they can develop with ventricular dysfunction. RV dysfunction is more commoner. Subsequently, will lead to LV dysfunction, and this presents challenges with the management in these patients, and identifying the problem with the right ventricle or the left ventricle at the proper time is the key to management in these patients. So what can be done in patients with RV to PA conduit problems? Either you go and exchange the conduit to a bigger size, yes, replace one problem with another problem, still do some catheter-based interventions, kind of prolong the life of the conduit that is present in the patient, so we get some more time to do a second operation or the third operation, or implant a transcatheter pulmonary valve in the position of the RV to PA conduit if it is feasible. What all catheter interventions are possible? We can either go and do a balloon dilatation of the conduit, which is stenosed, balloon dilatation of the branch PAs at the site of distal PA anastomosis, placement of a non-valved stent in the position of the pulmonary valve, but whether this will help really, because you are just putting a non-valved stent in position, it will increase the regurgitation, and it will hence increase the incidence of regurgitation and RV dysfunction or RV dilatation further. But still, they can prolong the course of action. They can buy some time for you for further interventions. Possibility of re-intervention with reduced risk, can't say, because interventions are not per se free of complication. You can have ruptures, you can have punctures, you can have infective endocarditis in these valves as well. So really, you can't say that there's a reduced risk. Ultimately, these patients will end up with surgery sometime or the other. This transcatheter pulmonary valve implantation, which was first described in the year 2000 by Bonhoeffer, and this was surprisingly again in a patient with a 12-year-old boy with an 18 mm RV to PA conduit that was placed 8 years earlier. This is transcatheter pulmonary valve implantation is coming up in a big way. There are a lot of studies that have been going on for implantation of these valves in this position. Of course, these are guided by the volumetric criteria and the systolic function, the tricuspid regurgitation, the gradient across the RVO, the occurrence of arrhythmias. These are all the guidelines that is for pulmonary valve with a patient with tetralogy of Fallot. I'm not going to detail of the numbers of all these things. That is a big thing, of course. Now, there are various, there are a few valves that have been approved by the FDA for implantation in these patients. This is a Melody valve that was first described for implantation, and subsequently there have been improvements in these valves. This is the Edwards Sapien valve. This is the first valve by the Carpenter Edwards company, of course, company-based. Then subsequently, the Sapien XT, which they incorporated a sleeve of Ptfe to prevent regurgitation. Sapien 3, which have better stent profile, better valve tissue inside, better orifice area, Medtronic core valve, not for pulmonary valve implantation. So Melody valve trial shows an excellent immediate and short-term outcomes. Of course, why these problems is because of fractures in the stent. These fractures have been caused because of the stenosis or the calcium that is already present in the conduit. To avoid these stent fractures, they have come out with pre-stenting these conduits and then implanting the Melody valve over these stents. So they have come on with various ways to implant the pulmonary valve. Sapien valve as well has shown immediate and short-term outcomes that have been really excellent. The advantage of these valves is they are available in smaller size, so they can be implanted in smaller patients. And the advantage is they can put a valve in a valve, and they have better orifice area or a smaller valve as compared to the conduits or the porcine valves that are in these conduits. But still, they're all immediate and short-term outcomes. Long-term is still awaited. We can't accept it as, kind of the treatment, but still they are a good option coming. Aortic regurgitation, again, in these patients, they are increasingly being recognized, but the numbers are very small to come ahead with any large papers. Why this aortic regurgitation occurs is because of the progressive aortic dilatation. We know that patients with tetralogy of Fallot and these variations have increased flow across the aortic valve, and because of this increased flow, they are already predisposed to dilatation of the aorta. They are known to have aortopathy, valvular problems per se because of these. They're not described exact mechanisms, but they are known to have valve pathologies per se, so they can develop aortic regurgitation, and this definitely increases the morbidity and mortality. What is the etiology as I described? Because of the increased flow from the right to left shunting, because there is a large VSD beneath the aortic valve, they don't have proper support. They can have prolapse of the right coronary cusp. Ongoing aortic root dilatation per se can cause valvular dilatation and cause regurgitation. They can develop infective endocarditis, native endocarditis of the aortic valve, and cause regurgitation. So this is one study where they claim that because the aortic regurgitation in patients with tetralogy of Fallot is commoner if they are associated with the right aortic arch, if they have taken a long time before the corrective surgery is done, male sex predilection for development of aortic regurgitation. Aortic dissection is another cause for development of AR, but the numbers are very, very low. And again, the disappropriate shading of conotracheal tissue between the aorta and the pulmonary artery is one important cause for development of aortic regurgitation. So what can be done for these patients? If they have mild aortic regurgitation at the repair of tetralogy of Fallot or pulmonary atresia TOF, you leave it alone. Moderate aortic regurgitation at the time of repair, definitely an attempt has to be made to repair the aortic valve, if possible, at the time of surgery, primary surgery. Of course, they have to be carefully followed up for the progression of aortic regurgitation. For the indication for replacement of aortic root in case of tetralogy of Fallot or for TOF with pulmonary atresia, not been described, no guidelines. But maybe if the root dilates more than 55 mm, may give a thought of replacement of the aortic root. But patients with aortic root as large as 80 mm have been described without developing complications or dissection. So you still can't have a strong guideline as to when to replace these. Arrhythmias are other cause of presentation into clinics. They can have either supraventricular arrhythmias, atrial reentrant tachycardias, atrial fibrillation, or atrial flutter. Per se, they can have a hypoplastic left atrium. There can be higher incidence of stimulation or excitation tissues, and hence they can have more incidence of atrial arrhythmias. The problem with these is because of the smaller size of the left atrium, isolation of pulmonary veins by the interventionists or the EPs can be difficult in these patients. They can have ventricular arrhythmias. They can have premature ventricular contractions or multiform PVCs. They can have either non-sustained or sustained ventricular tachycardia. The causes, of course, as I've described already, is a ventriculotomy site, RV incision, a patch in the septum with sutures in that site with fibrosis, older age at repair already causing some amount of RV changes in the RV musculature and the conduction patterns. One of the risk factor is an annual increase in QRS duration in patients, which has to be identified earlier, and these patients are at higher risk for developing arrhythmias. There are risks for sudden cardiac death in patients. It is LV systolic dysfunction or presence of diastolic dysfunction, presence of non-sustained VT already in a patient, QRS duration of more than 180 milliseconds, or increase in QRS duration progressively, extensive RV scarring, which can be identified during surgery or prior to surgery. And if there is an inducible sustained VT at EP study, these patients are at increased risk of sudden cardiac death, which guide further management in these patients. These patients can also present with hemoptysis in adulthood, adult age groups, because it is known to be a lethal complication. This hemoptysis is described in patients which usually have pulmonary obstructive disease like pulmonary atresia with ventricular septal defects. Though they are rare, but still in patients with pulmonary atresia VSD, they can occur in 12% of patients. That doesn't amount to a huge number of patients, but they definitely have been described. Why they can have hemoptysis? Because of rupture of the collaterals or the MAPCAs, which have become hypertensive. And the treatment for these is either embolization or appropriate identification and surgical ligation. Of course, embolization is preferred because surgical ligation is known to have higher mortality or morbidity in these patients who already have hemoptysis. Next comes the question of pregnancy in adult age group who have been following up adult congenital heart disease clinics. The right ventricle, the status of the right ventricle is very important when we are considering pregnancy in patients with the pulmonary atresia VSD who have reached adult age group. Now, if both the right ventricular and left ventricular functions are preserved, highly unlikely that the patient is going to have any problems. Even they have some in pregnancy, even they have some amount of pulmonary regurgitation. So unlike all, like all other regurgitant lesions, these patients can undergo pregnancy without problems. But if they have significant pulmonary regurgitation and have RV ventricular overload significantly, and they have some amount of changes already in the right ventricle, they definitely can have problem. And also these patients who are already having pulmonary regurgitation, if they have a pregnancy, because of the volume overload status, they can develop a status of irreversible cardiac modeling by the end of pregnancy as well. So they are at higher risk for complications post-pregnant status. Now, if the guidelines for pulmonary valve assessment is the same as compared to the regular guidelines for pulmonary valve replacement, if these patients meet this replacement before pregnancy, it is preferable to have a pulmonary valve replacement before embarking on pregnancy. And after such procedures, a recovery period of 6 months postoperatively is recommended for such patients after a pulmonary valve replacement. Now, this is by a single institutional study. These are not multiple randomized or data. This is a single institutional study, and this author has recommended a 6-month postoperative time gap before conceiving. Stenotic lesions, of course, they are less tolerated than regurgitant lesions. The guide for intervention for a stenotic lesion is peak-to-peak gradient of 50 millimeter mercury or the peak right ventricular gradient pressure of 75 millimeter mercury. In these patients, the incidence of atrial arrhythmias are quite high. No reason explained. These patients can safely undergo balloon valvuloplasty to tide away the crisis during pregnancy. they can easily develop LV dysfunction. They can have pulmonary hypertension before they reach adult age group, and these patients pose critical problems during assessment as well. Of course, these patients, as already told, have a higher incidence of atrial arrhythmias. They have worsening cyanosis and associated complications during pregnancy. They can have thrombosis per se because of increased thrombotic nature. They can have increased incidence of bleeding diathesis during pregnancy or during the postpartum period, and they can have irreversible cardiac failure because of RV dysfunction in the post-pregnant status. These patients, these pregnant patients, there is a higher incidence of fetal loss in pregnant women with congenital heart disease, especially pulmonary atresia, VSDs. And though they, the risk of fetal loss is present in patients who are not operated, patients who are operated don't have usually intrauterine deaths. The problems with them is they usually end up having children with low birth weight or prematurity. The importance of all these data is that you need to have good preconception counseling in an adult patient who is coming with pregnancy, or even before that in follow-up at adult congenital heart disease clinics, to make them aware of the complications of during pregnancy, and to have proper genetic counseling, because genetic the transmission of DiGeorge syndrome, if it is present already in a mother, is higher as compared to non-DiGeorge syndrome mother. So these things have to be properly counseled to the patient, and this is a very important aspect of adult congenital heart disease. Finally, after all these treatments, the patient can still have multiple conduits. They can have pulmonary valve replacement. They can have multiple interventions, not operated, operated, whatever it might be. They can come back finally with heart failure. And is heart and lung transplant the final answer for pulmonary atresia and VSD? This is one study from Germany that showed heart and lung transplant in patients with pulmonary atresia and VSD. They stated that the heart and lung transplant, particularly in this subset of patients, is difficult because they have numerous collateral vessels. If they are not operated earlier, there are unoperated patients. It's very difficult to tackle this during the transplant because they're usually large and hypertensive. If they have undergone operations earlier, they are usually multiple operations. So the adhesions are so much that it's very difficult to dissect the organs for transplant. And the anatomy that are coexistent in these patients are so high that they can have multi-organ problems when they present for transplant. And the challenge of transplanting in these patients is extremely high. They are usually in worse condition than other transplant patients, is what they have observed in that institute. If these patients are young at the time of transplant, that is a better situation for transplanting, doing a heart and lung transplant in these patients. If a cardiologist considers that the patient is not suitable for a shunt procedure or a corrective procedure in a near future, they should not go ahead for palliative procedures like shunts or other things. They can as well be followed up for transplant, but is it a valid option? The number of donors being less, the patients, there are various other factors which I don't, obviously you know all those things, so you don't have to go into details of those things. I don't know much about that, of course. Shunt procedures should be abandoned because they might actually worsen the natural history and decrease the chance of transplant. They do not improve the prognosis for the patients, and many multiple procedures, of course, increase the risk of bleeding and other complication during heart and lung transplant in these patients. Now, then comes the other important aspects of segmental pulmonary hypertension in patients with pulmonary atresia and VSD followed up in adult congenital heart disease. The definition of segmental pulmonary hypertension is either some segments of the lung rather than the entire lung being affected by pulmonary vascular remodeling and pulmonary hypertension. This is more common in pulmonary atresia, VSD, because of the MAPCAs or the lung vasculature per se. There are various combinations of segmental hypertension, and these are the reasons why segmental hypertension can occur in these patients. This is a patient where the PDA supplies the left pulmonary artery and the right pulmonary artery is supplied by a MAPCA. So they can definitely have pulmonary hypertension in both lungs, but they can have variation in the pulmonary pressures, but definitely in both lungs. There's another MAPCA that has been supplying to the left lung by the arch itself. This is another subset of patients where this patient has undergone a shunt. A patch shunt has already been done in this patient to improve the blood supply to the left lung. And this patient has a MAPCA which can be stenosed, cannot be stenosed. If it is stenosed, they can have isolated pulmonary hypertension of the left lung with no hypertension on the right lung. So this is one example of, it's one subset of pulmonary atresia, VSD, who can have segmental hypertension. The next subset is, in this case, where it is kind of hemitruncus with an unrestricted pulmonary blood flow to the left lung and a restricted pulmonary blood flow to the right lung. Again, they can develop segmental hypertension. Here, this can be considered as a patient who has undergone a RV to PA conduit earlier, but for some reason, the VSD has not been closed. This patient has a stenosis at the distal conduit to pulmonary artery anastomosis site. Because of this, the patient can have increased blood supply to the right lung, can develop segmental hypertension of the right lung, and the left lung may not have pulmonary hypertension. This kind of situation can happen in any of the branch pulmonary arteries. The branch distribution or the arborization patterns inside the lungs can be different in many patients, and hence the pulmonary hypertension that is developing in these patients can be varied as such. What are the effects of this segmental pulmonary hypertension? There is asymmetric perfusion or ventilation in these patients. Because of obvious reasons, there is decrease in the oxygen delivery. There is ineffective ventilation in these patients. And because of the presence of hypertensive segment and a non-hypertensive segment, because of the poor perfusion, they can have varied oxygen ventilation perfusion. They can have ventilation perfusion mismatches. Whatever may be the problem or the reason, overall, they put a severe stress on the heart and the lung, especially in patients who already had conduits or surgeries. They can have furthermore problems. There is a lot of discussion about pulmonary hypertension or segmental pulmonary hypertension. There is still no consensus on the best modality of investigation or anti-PAH therapies in these patients. Finally, they have the adult congenital heart disease consensus by the American Heart Association classifies these patients as 4 categories, who have category A as functional class 1 with no hemodynamic arrhythmias or normal exercise capacity, category B functional class 2, mild restriction of function or mild valvular disease or arrhythmias which are trivial, not requiring treatment, class C or group C, functional class 3 patients with moderate problems with the valvular lesions, hemodynamically significant shunts, arrhythmias which require treatment, and pulmonary hypertension presence but which are not severe or which have some end organ dysfunction which are responsive to therapy. Then they can have class D. These patients have NYHA class 4 symptoms, severe aortic root enlargement, regurgitation, severe hypoxia, severe pulmonary hypertension or Eisenmenger syndrome or refractory end organ damage. These patients should be followed up routinely in adult congenital heart disease clinics. If they are stage A, they need to be followed up at intervals of 1 year to 2 years. Stage B, a yearly follow-up. Stage C, half-yearly to yearly follow-up. Now, these are the most common subset of patients that we see in the adult congenital heart disease clinics probably. They are stage B and stage C, which needs at least yearly follow-up, yearly ECG, yearly echoes, and functional assessment by whatever means, exercise testing whenever needed in stage B and stage C at yearly intervals. Luckily, we don't see much patients in developed countries who have in stage D, but this is the follow-up guidelines for these patients. Conclusion, pulmonary atresia VSD MAPCAs is relatively rare, but still an important subset of patient. Treatment appears to be relatively straightforward. Should I say that? I don't know. Yes, all textbooks describe straightforward treatments, but it doesn't look as straightforward looking at the number of surgeries that these patients have to undergo. The perfect RV to PA conduit is yet to be found. This discussion is going on from years and still keep on going. I don't think we'll ever find a perfect RV to PA conduit. Explantation and reimplantation of RV to PA conduits is a norm in this condition rather than an exception. Multiple RVOT reconstruction with RVOT conduit replacement can be performed safely. Yes, can be said because of the increased surgical experience. And then more and more the number of cases that we are performing nowadays, multiple redo surgeries, these surgeries can be performed safely, but to what extent in everybody's hand can't be said. low surgical morbidity or mortality for these patients? Of course, mortality can be considered low, but morbidity, can it be considered low, considering that these patients are undergoing multiple interventions or surgeries again? Alternate management strategies like intervention, they prolong the interval for surgical intervention. Transcutaneous pulmonary valve replacement is one big thing that is looking attractive, but is still not time tested. We need to be careful. Multiple other problems like pulmonary hypertension, aneurysms, aortic regurgitation, infective endocarditis, which do not have optimal, of course not infective endocarditis, the other ones which do not have optimal management strategies. Finally, will all these patients end up with heart and lung transplant? Is it the ultimate answer? Do we have the capacity to do so much heart transplants? Don't know. All patients, however, deserve regular follow-up and of course an informed follow-up to keep these patients safe. And still, adult congenital heart disease has a long way to go. Thank you.
Thank you, Sri. It's a really excellent description.
Thank you very much.
Detailed. Due to shortness of time, we can have a short session of questions and answers, please, if you have that.
Well, very good, Sri. Actually, it was an excellent presentation, very detailed. Obviously, it's difficult.
There is a problem with the audio. Hello, can't listen. Hello.
To cover all the, can you hear me?
No, the voice is broken.
Attilio, we cannot hear you well.
Okay.
Oh, really? Then
I can
it's
hear
problem
you guys.
with me. Okay. Yeah.
Can you hear me? Can everyone hear me?
Yeah, yeah.
Is it better? Okay.
Better.
No, I was just saying actually it's very difficult to cover all the different aspects and facets of this very complex. In particular, the reconstruction of the pulmonary artery branches, that I think actually for me it's the most complex one, and as well the approach between thoracotomy approach in dissecting the MAPCAs and the central reconstruction, like so the one actually that. Can you hear me?
We're losing you intermittently.
All right, sorry. Anyway, I think well done. Actually, I don't have any particular question, but there are a few aspects that in pulmonary atresia VSD MAPCAs surgically are very interesting debates, like leaving the VSD fenestrated or not, materials to use to reconstruct pulmonary homograft versus non-homograft, and you have touched very well on the use of conduits. Thank you.
Thank you very much.
Well done, Sri. I think a very good comprehensive presentation. You covered quite a lot, actually. So,
I cannot reduce it further. Sorry, I mean, it was long. I know that.
No,
but...
no, it was good. It was good. I'm not saying that because it was good, that because you managed to touch quite a lot of things about the spectrum, the conduits, the pregnancy, and then long-term outcomes, including taking us into transplantation as well, which is very good. It's unfortunately it's a wide spectrum of disease. Every patient is different, so we have to. I think we have to plan our treatment strategies patient by patient, because it's a wide spectrum. Some are very good cases, very good outcomes you get, and some are very bad cases. But it's very interesting. Thank you very much.
Thanks.
Sri, can you hear me now?
Yeah.
Better.
Yeah, one comment on the conduit.
Yeah.
Can't hear you.
When I was in Birmingham with Ron, I learned actually that a pulmonary artery, you can. Hello?
No, voice is breaking.
Goes. Yeah, I'm sorry. Anyway, I'll tell you another time then.
Yeah, yeah, I'll call and then we can talk. Yes, I definitely.
Thank you all. Oleg, I think we need to do something to prevent this next week.
I'm not sure what's happened with these channels. I will have a look into.
The problem was I started a channel and Oleg started a channel. So there were 2 channels in that.
We
So
can
next time probably I have to start channel first, and
Yeah.
everybody can.
Exactly.
If
Once
you
Oleg
that-
starts the channel, then the speaker can join. That's the best
yeah,
option.
then you can take over, and then make sure that Oleg, there is only one meeting to join.
Yeah.
So we
Yeah,
can cancel.
okay, we'll do, because it's
Well,
first
well
time.
done, guys.
Yes.
Thanks.
Thank you.
Thank you
Send the
very much.
invite the day before, Oleg. Oleg,
Thanks,
send the
thanks, Oleg. Thanks,
invite the day before, so it is in our calendar.
Okay, we'll do.
Okay.
Okay. Yeah.
All
Thank
right
you
then.
so much.
Bye. Thank you.
See you next week.
What is it next?